Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking about melanoma and the surgical options for removing this form of skin cancer and treating the serious skin disease with surgical oncologist Russell Brown. In the second half hour of our program, we'll be taking your questions, like we always do, by phone at 504-866-3200. There's our number. And by email. You can email your questions to us at that address, hhquestions@wlae.com. We're taking email questions now. We'll ask you to hold off on the phone calls for just a short while. Well, Dr. Russ Brown received his medical degree from the University of Texas Health Sciences Center in Houston. He's from Texas. He completed his residency, though, here at Ochsner, fell in love with the city then, and fell in love with his wife. His fellowship in surgical oncology took place at the University of Louisville. Dr. Brown, whose practice is dedicated to cancer patients primarily, is board certified by the American Board of Surgery, and it is our pleasure to welcome Dr. Russell Brown to Hello Health. Good to have you with us on the program.
Good to be here, Tom.
Yeah, thanks. So who was it, do you remember, who was it or what was it that first interested you in medicine?
So my father's a doctor, like most doctors' kids, I didn't want to be a doctor. Went to college, studied engineering, and then kind of came around to it and grew into it.
Yeah, what kind of what part of Texas did you grow up in, and what kind of
I grew up
doctor
in
was
East
your
Texas in a town called Woodville. It's about an hour north of Beaumont.
Okay.
My dad's a family practice doctor, one of a few doctors in a small county there. It really has kind of a Norman Rockwell practice,
right?
What you would advertise family practice to young medical students.
Yeah, and Dad's still going, right?
He is
still practicing. Wonderful. Well, and what brought you to New Orleans? You did your residency work here, right?
I was lucky enough to do my residency here at Ochsner. Had a blast in the city. Received great training. Ended up circling back. I was here during the hurricane. Met my wife here. We went to fellowship and then have found our way back to the city.
Great, and you have a 2-year-old son?
We do. Trip.
Yeah, good. Congratulations. Thanks. Well, tonight we're talking about melanoma, a form of skin cancer, not the only form of skin cancer. So we probably should use a broader brush first. Talk to us about the different forms of skin cancer, doctor.
So there's lots of different forms of skin cancer, some of which you may have heard of, things like basal cell carcinoma and squamous cell carcinoma. Which would be the most common kinds of skin cancers. There's lots of benign things that are pre-malignant that people will talk about having scraped off or burned off or something like that. Those are completely separate kinds of cancer than melanoma is. So today we're going to talk about melanoma, which is a little more serious.
That's right. This is our primary focus. So let's run through melanoma.
So I guess the definition of melanoma would be it's a kind of skin cancer that develops in pigment-containing cells that are called melanocytes. So that's what gives all of our skin, no matter our complexion, it's what gives us our skin tone and color. Melanoma is a malignant kind of cancer, meaning that it can grow and spread to other organs. And then we already talked a little bit about it being different than some more common things like basal or squamous cell cancer.
Okay. You brought along an illustration too. We're taking us all back to biology class. What makes up the skin and where this cancer?
Yeah, there's lots of layers to the skin. This is kind of a simplified drawing, but this is a cross section of the skin. So if you cut a piece of skin off and looked at it from the side, this is what it would look like. The top is the epidermis. Under that, there's several cell layers, and at the very bottom would be the subcutaneous layer, or what we think of as fat. And then these dark oval shapes, this is just a cartoon, but it's kind of gives you a sense of a melanocyte changing into a tumor and getting thicker. So we would all rather have a thin melanoma than a thick melanoma. Thick melanomas are more aggressive, and that's kind of what this is showing. Okay.
You mentioned pigmentation of the skin. So I've got I'm jumping ahead here a little bit, but getting a free doctor's visit. I've got a small, on my chest, very, very small little dot that's white. It's almost like there's no pigmentation there at all. And I can't remember that being there. Is that something that's worrisome or troublesome?
It kind of depends on the size and what it looks like. So there are small white dots that are everything from just a simple fungus, and then there are small white dots that can be cancerous. In general, without having seen it or having a biopsy or something like that, in general, a small white dot is probably going to be benign. But,
okay.
And we playing the odds here.
Yeah, and we won't be showing. We won't be.
I was
going
to dare you. I was going to dare
you. Maybe tonight, but not right now. All right. And in this, with anything else, and this really is a theme to your presentation tonight too. When in doubt, start with your primary care physician.
Check it out. So the primary care docs are the real gateway for this. I mean, they see certainly more patients than any surgeon ever does.
Or dermatologists.
Or dermatologists. They get used to seeing the human body in all its forms. They see, common things are common and uncommon things are not common, and they know the difference between those and can help stratify people, who needs this just watched, who needs to see a dermatologist, who needs to go to a surgeon.
All right. So we've already established melanoma is a skin cancer, but how serious is melanoma as a skin cancer?
So all melanomas are malignant. The degree of which that they're malignant changes, and melanoma can range from something that's highly curable that we can almost assuredly say will never bother someone again the rest of their life, to more aggressive melanomas that can spread to lymph nodes, other organs, and can certainly kill people. I think this slide is just showing that it can be deadly. It's expected to kill about 10,000 people this year in the U.S.
Okay. And typically when a melanoma is removed, and we'll talk about treatment options later, do they tend to grow back or not?
So we worry, I tell patients all the time, we worry more about a melanoma showing up somewhere else than we do the actual melanoma coming back in the area that we took it out with surgery. And the reasons for that, I think we'll touch on that a lot tonight. The reasons of that are poorly understood. We're starting to learn more about it, but it has a lot to do with the patient's immune system and their interaction with the tumor. It has a lot to do with the actual tumor or the melanoma's biology and how aggressive it's going to be.
Okay, and then most cancers spread through lymph nodes, but bloodstream as well, right? Which may be another cause.
Yeah, melanomas can spread through lymphatic systems and also through the bloodstream. They can go to places distant. Someone may have a melanoma on an extremity on their arm or leg, and then later it show up in other areas of the body that we really can't connect through a lymphatic system or a certain blood vessel.
All right, Dr. Brown's brought along some statistics from the American Cancer Society, so let's look at those now. This is a bigger issue with men than it is with women, but certainly an issue with women too.
Right, it's about even. But this slide, which is not come up yet, but it's coming.
There it is, yeah.
So here we go. So on the left is a cartoon of a male, so the column on the left is statistics regarding males. The column on the right is statistics regarding females. You see at the top, prostate cancer would be a common cancer among males. Breast cancer would be a common cancer among females. Melanoma's down there, number 5 and number 6 respectively, between the two. And then I think we have the next slide.
Yeah, what do we see in this graph chart next?
So next, the axis on the left is a rate or number of new cases within a given year, and along the bottom is the years which on each graph. The right would be relatively current, and then going back in time from there. So melanoma is at the bottom, maybe hard to see on your TV screen, but on the bottom, the purple line is melanoma, and the thing I wanted to point out here was that melanoma is kind of on the rise decade by decade, and that's something that is borne out in several studies and continues to be. So we're starting to see it as more of an epidemic than we used to.
So reported cases, because you think it may have been around much longer than this, and the statistics may have been this high, we just didn't, it was underreported.
Some of that is underreporting, some of that's people are living longer now than they did 30 years ago. So as people live longer, they become at more risk for developing a melanoma.
And are you surprised, because we have so much more information now, right? We're warned against, when I was young and growing up, somebody may have mentioned sunscreen, and now, we're told don't let your kids, in fact, don't even walk out of the house, not just going to the beach, on your way to work.
Yeah, so we're hoping that with time, we all have, we're stuck with our skin our entire lives, so we're expected to be stuck with the skin we were born in for 70 or 80 years, and your risk of melanoma goes up the longer you have that skin and how you take care of it. There's some genetic predispositions to melanoma, just like there are with all skin cancers. So there's really a lot of factors. It's not something we can point to, that you got a sunburn on your arm, therefore your arm is at risk for getting melanoma. We have some pictures later, but you'll see you can get melanoma in places that have never been exposed to the sun. So it's hard to kind of wrap your mind around that sometimes.
And do we know why melanoma gets triggered in some people and not others? There are people who burn all the time. There are people with different skin pigmentations. Do we know what it is that triggers it?
We kind of know some rough, we know what kind of people are more at risk than others, but certainly fair-skinned people, red-headed, freckly Irish people are at higher risk of developing a melanoma as a group than African Americans, but we see it in African Americans also. So it's just like, or it's similar to smoking and lung cancer. We know there's certainly a cause there, but we all know people who have smoked their whole lives and will never develop a lung cancer, and we know people that have never smoked and will develop a lung cancer. So it's multifactorial: genetics, exposure, things like UV radiation. We know that's the sun exposure part of it. Smoking is a risk factor for melanoma.
Well, as we see it becoming more and more of an issue, we all probably know someone who's had to deal with melanoma, or at least listened to someone, or voted for someone, or watched someone play in a football game. You brought along some photos of celebrities who all had cases of melanoma.
Yeah, a lot of these folks don't realize that melanoma has touched people that are in the news, and they're still doing fine. Jimmy Carter was in the news a couple of years ago. He had a melanoma that showed up in his liver. He's benefited greatly, certainly, from some newer developments in immunotherapy and targeted therapies for melanoma.
Yeah, and he's in his 90s and still building houses and going stronger than ever. Yeah.
Right.
Bob Marley?
Bob Marley died from melanoma in his youth. He had a melanoma on his toe, was advised to have his toe removed. They thought it was a soccer injury, but eventually was diagnosed with melanoma that metastasized and ended up taking his life.
I worked in Washington when Sam Donaldson was covering the White House.
Sam Donaldson also, he's been an advocate for melanoma. He had a melanoma that showed up in a lymph node. He's been treated and is doing well.
John McCain's been very vocal too about his skin cancer.
He had a head and neck melanoma that was involving some lymph nodes, and he's been treated and doing well. Troy Aikman was very vocal and advocated for melanoma. He, I believe, had a thin melanoma on his back, was in the news for a while related to that.
And what about survival statistics? You brought along a chart here that would be helpful for us.
Yeah, this is, doctors love to show survival curves, and they're hard to kind of understand, but the axis on the left, the vertical axis, is the proportion of people that are alive with a certain stage of melanoma, and each line is a stage of melanoma, and I'll talk about that in a minute. And then on the bottom is the number of years since they were diagnosed. So as you go towards the right on the graph, that's more time since being diagnosed with melanoma. And then basically a stage 1 melanoma would be an early melanoma involving just the skin. A stage 4 melanoma would be one, the worst stage of melanoma that's spread to another place. And in between are kind of the in-between stages. So With time, there's a certain number of people that will have melanoma come back, and we have a hard time understanding why this person with a stage 1 melanoma is going to have no more problems the rest of their life, but a small percentage of them will have a problem. And I think that's all we're supposed to show here.
Okay. Melanoma typically a fast-growing cancer?
No, that's a common question. Most cancers we think have been there for quite a few months or even years before they're diagnosed. We all have patients that have a melanoma that they can find a picture that nothing was there and now something's there. But that's a poorly understood thing about how long it takes a melanoma to develop. Most melanomas will start in a pre-existing skin lesion and then change and evolve. You can also have melanomas that develop when there was no pre-existing skin lesion, a de novo melanoma.
So safe to say, because it is not growing quickly, that someone who sees their primary care physician once a year, an annual checkup, and is looking for these sorts of things, would have a better chance of finding melanoma at its earlier stages?
I think it's safe to say that, yeah. I think it's definitely safe to say that, and it's something that we want to get out there, to be aware. Look at your spouse's skin. Listen to your barber when he tells you you've got a problem, things like that.
Right. Now, and I'm thinking going to my primary care physician, it's not often that I'm completely undressed in front of a primary care physician. Is that the sort of thing that you would suggest? And if so, at a certain age?
No, for years that we've tried to, no, some public health doctors have tried to sort that out, and that's not recommended as part of the screening, but I think being aware and bringing those things to your physician's attention certainly are. So, there's no requirement that you strip buck naked for your physician every year. You'll certainly find some physicians that's their practice, and that's okay too.
Right. Talk to me about moles. I don't think we had that scheduled to talk about, but certainly we have heard that some moles can turn into skin cancer.
Right. That's very true. A mole is kind of a colloquial term for anything that, a spot or a lesion. You'll hear these words thrown around by doctors all the time. Moles are typically a benign thing. It's hard to, it's hard to explain the art of what dermatologists do or what doctors that see a lot of skin conditions or what surgeons can do, but they know a mole when they see it. If there's any question, then they usually will biopsy it and have it looked at under the microscope and given a name is what I say. So sort it out, and we'll have a piece of paper that says what it is. And sometimes that's an important step in deciding, is this mole a nothing or is this really something we need to worry about?
We've heard of people having moles removed. Dermatologists says, let's get rid of it, even though it's not an issue. You have a 2-year-old son. Don't know if he's got any moles or not, but are you going to have them, if there's a mole that doesn't look like it's an issue when he's 5 or 6 years old, are you going to have him removed?
Probably not, unless I thought it was an issue or his pediatrician thought it was an issue or a dermatologist did. We all have, anyone in your household is going to have a mole on them somewhere. If you, a lesion, a skin lesion or something, the majority of the time that's going to be benign.
Okay. And what causes them? The normal ones, either the freckles or moles.
Yeah.
Why do some people have them, some people don't?
Some of that is sun exposure. Also, you can see people that will develop freckles and moles in sun-exposed areas, so it's sun damage. It just heals as a mole. Some of it's genetics and the kind of skin that you're born with. Some of it's a process of aging.
Okay. We're visiting with surgical oncologist Russell Brown, and we're talking about melanoma tonight, a very deadly form of skin cancer, can be. We're talking about diagnosing it and treating it. We'll get to some of those treatment options in just a couple of minutes. Doctor, talk to us about the diagnosis process, starting with a primary care physician, then eventually moving to someone such as yourself.
Yeah, so we teach medical students and residents and primary care doctors all carry around this knowledge of ABCDs. I think we all learned this the first year of medical school, but it applies to the general public too. So A stands for asymmetry. It's where if you look at that first mole, I'm not sure how well this projects on your home TV, but hopefully you can see it. I think you can all appreciate that half that lesion is certainly different than the other half of the lesion. And then B would stand for border, so the border of that lesion is irregular. It's not smooth and round, and it's irregular. C is for color. Most of us think of melanoma as a black spot, which that spot certainly is black, but I can tell you for a fact that that pink area is also tumor, is also melanoma, and you'll see in some of the slides we have later that it's not always just a black spot. And then D is for diameter, so we'd like to say that any skin mole, lesion, spot, whatever you want to call it, that's bigger than about 6 millimeters, which is roughly the size of a pencil eraser, should probably be looked at by someone, your doctor, show your wife. Somebody ought to be looking at it. And then E is for evolution, or a history of changing it. So a lesion that, was there and was doing fine, but now for, no good reason, it's bleeding or it's itching or something's changing about it. It's getting larger than it used to be. Those are all red flags.
Right. 5 years ago, 10 years ago, certainly we didn't have cell phones and cameras in our hand all the time. Is that something you would advise, that if you see something that looks suspicious in any way or something you didn't notice before, take a picture of it, and that way you can come back later and compare it either for yourself or your spouse, or to share that with your doctor?
Yeah, I think that's a useful thing to do if you can't decide, and you maybe aren't going to see your primary care doctor for a month or two, and that's certainly better than nothing. Many dermatologists in their practice will photograph patients that are at risk for melanoma and track their moles through time, and they find that to be useful. So.
All right. Well, you have done that, bringing some pictures tonight of different melanomas and in different forms, and we're going to show these pictures now. So if you could kind of walk us through these.
Yeah, these are from patients. I think this is a group of pictures, and it shows how different melanoma can be. This lesion on the left is from a oil field worker. He had this spot. He's young. I think he's in his 30s. He had this kind of smudge spot on his cheek, which his kind of buddies were making fun of him, and he showed up to the doctor. This is a picture that he brought with him. He did what you said. He took a picture of it. This was biopsied and turned out to be a very early melanoma. The lesion on the left is more of a nodular-looking melanoma. It kind of looks heaped up more than flat. The one on the bottom left is a melanoma that developed just off of someone's earlobe there, and they thought that was a sore. So they tried various things to try to fix it, and it'd scab up and not heal, and eventually made it to the doctor, and they diagnosed it as a melanoma. I think that physician was probably surprised that was a melanoma too. And then this lesion on the bottom right it's kind of similar to that other lesion we showed. So you could probably predict that this was a lesion that had been there before, that started to change. The color of it started to change. You get these dark spots and light spots in the middle of a lesion that had changed.
That one sort of fits all the definitions: asymmetrical, different color.
It does.
Border issues, right? So that
I think the one on the bottom right, I think pretty much any doctor would have a problem with that and refer it for either a biopsy themselves or to a dermatologist to sort out.
Right. Is there a general rule? You mentioned they thought it was just some issue. They treated it with a topical or whatever, and it didn't go well.
That's kind of another flag, a red flag. If you've got some skin spot and you've put some homemade salve on it or done whatever you tried to do to fix it, and it's really not getting better, then that's really a problem. Most of these things don't hurt at all. Most things that patients are trying to treat would be infections that would be tender or hurt. So lesions that look like this, that you think, well, this is no big deal because it doesn't hurt, you really need to kind of keep an eye on them or bring them to the attention of your doctor.
All right. We'll continue on with our series of slides. What do we see in this next one?
This is just another 4 shots of various melanomas. You can see that one on the top left has started to get more heaped up with time. The lesion on the top right, I think, is what most people think of as a melanoma. If I asked them to take a multiple choice test, that would be the one that stands out to you. It's a black spot. The one on the bottom left is on a gentleman's scalp. You can see the red spots were where it was ulcerated or excoriated. It would bleed and heal, and then the nodular part is a more obvious melanoma. And then on the bottom right's older lady who had this spot on her pinky finger that she swears started as a burn. We hear that story a lot. It probably did not start a burn. She might have burned her hand, and that brought her attention to it, but that turned out to be a melanoma, which you can get. Nobody that I know has a sunburn on the palm of their hand, but you can certainly get a melanoma there.
Right. And in this next slide, what do we see?
This is a gentleman who I saw about a year ago. His barber found this lesion, which you can't really see kind of on the picture on the top. You can kind of maybe appreciate something there, but his barber nagged him for a couple of years before he went to the doctor. Between the barber and his wife, he went to the doctor. They found this melanoma, which is broader than you can see there. So, in the hairline, you can't name a place on your skin where a melanoma has not been described. So, these things happen.
Okay, I understand we're having some problems finding that particular image, but you talked about how primary care physicians are trained to look for these sorts of things. Are barbers, only because you bring it up,
yeah, it happens a couple times.
Trained?
Well, I haven't seen the barber in a while, but you do hear this story.
I'm with you, my friend.
You hear this story a good bit. I mean, they'll see spots. I'm sure the majority of them are benign, but it's something they see. And I think many barbers, if you talk to them, will have found a skin cancer, and they tend to, and beauticians, I shouldn't leave out women in this either, but
right.
They see things on people's heads that they can't see. You can only see half your head at one time.
And if you think about it, the people who go to the same barber typically go once every couple of weeks or at least once a month, and might even notice something that looks different than it is.
It's a story you hear kind of over and over.
Yeah, good for them. This next case is these next cases are pretty severe ones that you wanted to share.
Yeah, these are a couple of patients through the years. I'm showing to maybe scare the hell out of people and get them to think about their skin a little bit. So this is an advanced melanoma that has metastasized in an in-transit fashion. That's what we call it when it's.
This looks like it could be an arm or a leg. You said this is a leg, right?
Yeah, it's marching up. This gentleman's. This is the front of his leg, but it's marching up his calf. This has happened over years, and he had a lesion that started on his foot, and it's kind of marched its way up through the lymphatics in the skin, and looks like this.
So it can be on the extremities, but also on the back area, and that's where we see this next one.
Yes, this is a gentleman who had this lesion on his back for years. At first he would say he could feel it, as a sore. It didn't really hurt him, but he could tell something was back there, and he kind of picked at it and ignored it. And then with time, I mean, these things can, left untreated, they'll grow and spread. You can see this bump in his neck. That's a lymph node with metastasis in it. This bump right in front of his muscle in his neck.
Okay. Melanoma is almost always going to start on the skin, but can actually get into the body. And we talked about that earlier, through the lymphatic system or even in the bloodstream. And you brought along an MRI to show us where it's actually made it to the brain.
Yeah, this can happen with melanoma. It can spread to organs inside the body, such as the brain. So this white spot is a melanoma metastasis to the brain.
Okay. What are some of the risk factors for people developing melanoma? Sun exposure, I think, is
I think a lot of people know that. So
yeah.
Blistering sunburns increases, history of a blistering sunburn, which many of us in the South have, increases your lifetime risk of getting melanoma by 80%. Use of tanning beds, which we could talk about a lot, but should probably be banned for young people especially, doubles your lifetime risk.
And there is no such thing as a safe tanning bed, is that?
No, I don't know of any.
Okay.
People with fair skin are increased risk of developing melanoma, as we've seen with Bob Marley and others. This is something that can happen to people of all races. Males are at higher risk than females, but we certainly see it commonly in females as well. Older people are higher risk. And then I think can we go back to the slide?
I was just going to ask you, we'll try to take a look at that.
Yeah.
But does it tend to run in families? And if so, is it just because most people have the same pigmentation?
Right. It goes two things. So one part of it is that, one of the things you inherit from your family is your type of skin. So you just, if you have fair-skinned parents, you're liable to be fair-skinned yourself and have an increased risk of developing skin cancer cancers of all kinds. There's some genetic conditions that are relatively rare that people are at really high risk for developing melanomas at early ages.
So what can we do, doctor, to reduce the risk of us developing melanoma?
So the basic things I think people know about but don't necessarily practice as often as they should are things like protecting your skin from sun damage. So staying out of the sun is better than being in the sun. If you can't do that, then doing things like protecting your skin with clothing and sunscreen, avoiding tanning beds really at all costs. I think they should be shut down. Look at your skin, have your family look at your skin, and really, take the time to protect your family and friends, especially young kids. That's you have to live with that skin long after you're dead. You might as well protect them while they're young and do the best you can.
All right, and often they're not making their own decisions at
They're
that
not
point.
If they are, they're probably poor decisions.
That's right. So talk to us about the team of people involved in diagnosing, finding melanoma, first of all, diagnosing it and treating it. We are going to get around to treatment options in just a moment.
Yeah, a huge number of people involved in treating a melanoma once we find it, but the people at the front line, we talked about our patients and their families and primary care doctors. They see these things and calls it to their attention, get it biopsied, referred to a dermatologist who take care of the bulk of skin cancers. That gets sent to a pathologist, which is an important part of this whole spectrum of people taking care of these things. Give melanoma a name, tell us how serious it is, how thick it is, do we need to do, what kind of surgery do we need to do. That's an important piece of information for people like me that are surgeons that do surgery on the skin, work on getting that back together after we remove that piece of skin. Sometimes have to do some surgery on some lymph nodes. Sometimes do some surgery when melanoma spreads to other organs. Things like people like oncologists that formerly, maybe 10 years ago, we didn't have much of a role for oncologists. There were chemotherapy options available for melanoma, but they didn't work very well. They're starting to really have a renewed interest in melanoma because of some newer therapies. There's ongoing research, clinical trials. I think Oxner has about 4 clinical trials open now for melanoma patients. Can't forget the nurses. My wife's a nurse. And, they do a ton of work helping to keep with everyone else taking care of these patients.
Right. The traditional treatment option is surgery, and that's where you spend a lot of your time. Let's talk about treating melanoma.
Yeah. So once someone has a melanoma, we diagnose it. Assuming this is early melanoma, which most of them will be, the bulk of the heavy lifting is done by surgical resection of that area. So that is as simple as taking a ruler and measuring a certain distance out, removing a piece of skin. Often don't need to remove muscle or anything like that, and then getting that back together. Sometimes as simple as just closing something with some stitches. Sometimes you have to make a little flap, or sometimes you have to do a skin graft or more advanced reconstruction. People with melanomas of certain thicknesses will often talk to them about doing some surgery on their lymph nodes to see if they're at risk for having melanoma in other places in their body, maybe stratify or help decide if they need additional treatments besides just surgery. Newer things that weren't available 10 years ago that are available now, things like immune therapies and targeted agents and chemotherapies, those are usually for stage 3 and 4, so more advanced melanomas. So those are certainly involved in the treatment of melanoma.
Okay, and then you brought along 2 additional slides with photos probably of the surgery and the healing. Talk to us about the healing process. I guess it depends on how much skin you have to take, but do you have patients who you wouldn't even know there was an issue there before?
Most people do very well after melanoma surgery. Most of these are surgeries that are either done in the office and you're awake for the whole thing. We numb it up and you go home. At most, people come to the hospital, have some surgery, and go home the same day. This is a slide of a thing called a sentinel node biopsy, which is a little advanced, but basically the basics of it would be that we're injecting that melanoma, which is in the center of that blue area. So that's dye that we've injected. And then we follow that dye with a radioactive probe and also with our eyes up through a little lymphatic channel into that lymph node, which on the picture to the right, the area that's the little trail leading up to a blue area, the blue area at the top is a lymph node. And then you can see that's a vein running next to it, the tube that looks like a vein.
Mm-hmm. And in this last image, what do we see here?
It's coming. Yeah, so this is what we try to shift stage migration, or we try to shift the patients that we're treating. So we would like not to treat the patients on the left. We don't see this as often, certainly as we used to, or the people who trained me used to see. That's a gentleman who has a melanoma metastasized to a lymph node in his armpit that we can all see across the room. And then if you cut that open, you don't need a microscope to see it. It has melanoma in the inside of it. And then we've tried to shift stage 3 melanoma, which is a melanoma spread to a lymph node, from being gross disease that we can feel and see and cause people trouble to really disease that we've identified under the microscope, and maybe get those people treated earlier onto a clinical trial, really try to advance the disease that way, the treatment of the disease that way.
You talked about Jimmy Carter and some treatment, newer treatment that he's undergone. What are the new developments in the treatment of melanoma and skin cancer?
So, we're doing less invasive surgeries than we used to. This thing called a sentinel node biopsy, we're doing less additional lymph node surgery than we used to. There's a trial that came out a couple of weeks ago, which is kind of a big deal for us, that came out of it's a trial called the MSLT2, which is many institutions participated in. It was several thousand patients.
And what's exciting about it?
It's exciting because it's it doesn't apply across the board to everybody, but it really has helped us decide who needs larger morbid surgery and who may not. So it's really answered some of those questions, and many people that formerly we would have absolutely recommended a bigger surgery, now we don't recommend that as often, which can help people in their recovery.
Okay. I remember, I want to say it was a surgical oncologist on this program predicting there would be a day when no one would die from melanoma anymore, with gene therapy and turning the body itself on skin cancer. Do you see? You said you also wanted to talk about it. I'm not sure if you're ready to make that prediction.
I don't know. I can't put a date on it, but we certainly all hope that we're there one day. People that treat cancer, we're really in the business of putting ourselves out of business. Which is a unique profession. There's immunotherapies that use the body's innate immune system to fight melanoma, rather than some of the other strategies that have been tried in the past, or maybe strategies that work in other forms of cancer. Things like chemotherapy, which are toxic agents that we give to kill not only melanoma or cancer cells, but unfortunately normal cells don't really work that well for melanoma. Over time, physicians and scientists have taken a different tack towards beating it.
All right. We're going to review everything we've talked about in a moment, but right now we want to invite you with your questions for Dr. Russell Brown. We're ready to take your calls and emails. Our number is 504-866-3200. That's 866-3200. Or you can email questions to us at hhquestions@wlae.com. We'll be back with your questions in a moment, and again, when we come back, we'll review everything we've talked about. This is Hello Health on WLAE.
I love taking care of my mom. It wasn't easy at first. She learned how to better communicate her needs.
And you learned how to not ignore yours.
I discovered how to make healthier meals.
And I discovered how much I enjoyed them.
Becoming a caregiver is a learning experience for everyone. Find articles, tips, and tools from experts and others who have been in your place. The Caregiving Resource Center at aarp.org/caregiving.
With the
And welcome back to Hello Health. I'm Tom Bagwell. Good to have you with us. Tonight we're talking about melanoma, one of the deadliest forms of skin cancer, with surgical oncologist Russell Brown. Our phone number is 504-866-3200. That's 504-866-3200. We do have phone lines open. You can also send us questions by email. Our email address is hhquestions@wlae.com. We'll review in just a moment. But doctor, we didn't talk about Mohs surgery. Mohs surgery, is that effective against early stage melanoma or not?
So Mohs surgery is mostly used for the very earliest melanomas, or in situ melanomas, or another word is lentigo maligna. These are really pre-melanomas, are really the earliest thing we can call a melanoma. So for invasive melanoma, less of a role for Mohs. It has some use in some special areas of the body. It's done in a different way than maybe your neighbor had Mohs surgery for a basal cell or a squamous cell cancer. It's done in a different way over many days rather than just in the office where they've frozen the sample that they've taken out, decided if it had cancer or not, and moved on or quit. It's hard to do that for melanoma for some technical reasons.
Okay. And again, most of the cases you're going to deal with are more severe cases and probably a little more advanced than that, correct or no?
A little bit. It's just a different technique that is great for basal cells and squamous cells. It's great for some in situ melanomas. It's just not commonly applied for invasive melanomas.
All right. Again, our phone number is 504-866-3200. That's 504-866-3200. Doctor, we have an email question here for us. Here we go. If my father has had melanoma, am I at greater risk?
So the short answer would be that yes, it's hard to quantify that risk for a specific person without knowing all the history. But, you know, like we talked about before, you've inherited skin qualities from your parents. Your father would be one half of those qualities. So it does increase your risk. It certainly doesn't mean that you will develop a melanoma.
All right. Another email question. Doctor, can basal or squamous cell cancer develop into melanoma?
No, those are a basal cell cancer and a squamous cell cancer are completely different than a melanoma. That's a different kind of cancer. That's as different as lung cancer and a colon cancer. Those are different things.
Do you find people tend to have more than one, even though they're different, and maybe even in different parts of the body?
Yeah, they are different kinds of cancers. They can occur in the same parts of the body. They're all related to sun exposure, some more than others, but they do tend to kind of run together, but they're different members of the family.
Okay. And do we know why some people who are exposed to the sun their whole life don't have any issues, and other people who take great precautions develop skin cancer?
No, we can't point to that reason exactly. We all know someone who smoked their entire life and will die of something other than lung cancer, and we all know people who have never smoked a cigarette in the day of their life and
develop lung cancer.
Develop lung cancer.
That's right.
So it's multifactorial.
Right. Do have phone lines open, 504-866-3200. That's 866-3200, and you can call us right now. Doctor, here's another email address, or you can also send us questions by email address, as these folks have, at hhquestions@wlae.com. Doctor, can I make an appointment directly with you, being a surgical oncologist, or do I have to go through my internist or primary care physician?
Some of that depends on your insurance company. Some demand that you see an internist first. Most of the people I see I'm in the fortunate position that I work with a lot of dermatologists in the region and a lot of also primary care docs, but I have the real luxury that most of the people come with a piece of paper that says what they have. I don't have to do a lot of head scratching to figure out what the problem they have is. So the route that most people will come to see me is through another doctor. But if someone's worried and their insurance company doesn't have some problem with it, I'm happy to see them.
Have you found that insurance companies have evolved with this as more and more cases are reported and supportive of these treatments?
Most of them tend to go through the specialist route, but things have opened up with time as well.
Okay. By the way, before we get to this next email and phone calls, we're all advised to see a primary care physician at least once a year. Would you, and again, not a dermatologist, surgical oncologist, but would you advise people to see a dermatologist on a regular basis? And if so, how often? And is that going to be determined by some of these risk factors we've talked about
A lot
tonight?
of it's determined by risk factors. So certainly once people have atypical moles, which is a diagnosis often that we have to get under the microscope. It's not just something that people look at, but once somebody has an atypical mole or an early melanoma, those people are seen very often, up to every 3 or 4 months by a dermatologist. The general public probably does not need to see a dermatologist every year, but there are people that have high risk for melanoma, maybe because of their family, or their skin type, or their history, that they need to see a dermatologist more often.
What is biopsying? What does a biopsy look like? What does it feel like?
That means taking a piece of tissue from
Right.
somewhere. So that can be everything from a little shave biopsy where you take a tangential or on the side shave of skin, to a little punch biopsy where you take a little small sample of the full thickness of the skin, to cutting a whole lesion out. So it really, that's kind of the art of what primary docs and dermatologists and surgeons do, is decide which kind of biopsy is right. But the simplest answer is it just means it's taking a piece of skin and putting it under the microscope and deciding, what this something is.
And that usually doesn't happen right away, right? So usually it's sent off to a lab somewhere, or someone's reading the slide and getting that information back.
Yeah,
and how
that's
often
kind
does
of
that usually take?
yeah. That's a unique. With melanoma is unique in the sense that you can't get a quick answer. It often requires some special stains to take a look at it. The turnaround time is variable between labs, but it's not going to be an overnight answer.
Okay. And when you're going in for surgery for a melanoma, do you typically know what you're going in for on the front end, or is that why you're shooting in that dye? You're kind of going along based on what you see?
So that dye test is a sentinel node biopsy. So we're doing that to try to figure out whether somebody has a melanoma spread to a lymph node or not. So in that case, we don't know when we go in what we're going to find. So that's a little different than things like breast cancer, where we use that same dye technique. Maybe we can have somebody asleep, ask a pathologist to look at this really quickly, give us the answer yes or no, and then move on with whatever we need to do. Melanoma, we almost never can do that because it requires some special staining, some special pathologists to look at it.
Okay. Again, our phone number is 504-866-3200. That's 866-3200. Here's another email question, Doctor. Other than a visual look at the skin, how else can melanoma be determined? A blood test, for example. This is a question from Pam. Pam, thank you.
Yeah, thanks, Pam. So there's no blood test for melanoma. There's just not a blood test for melanoma. There are great blood tests for things like prostate cancer, for some other kinds of cancer, breast cancer. We don't have good blood tests. And melanoma's right there with it. We don't have a great blood test that we can just get a blood sample and say you have melanoma or you're at risk for melanoma.
All right.
Maybe that'll come up one day.
All right. 504-866-3200. That's 866-3200. Or send us your questions by email. And there's our email address at the bottom of your screen, hhquestions@wlae.com. Another email question, Doctor. My daughter had a very dark mole. She has had it removed twice, both coming back as non-suspicious, but it has grown back again. Should I have it removed again since it is still very dark?
Hard to know the specifics. I'm glad that your doctor sent it off. It sounds like they've sent it off and had a piece of it and came back as non-suspicious, is what you're saying here. If it's come back, that's probably something that should just be formally removed with a small surgery and kind of put to bed. Is this a cancer or not a cancer?
All right. Our first phone call tonight is from Ann calling us about melanoma. Ann, you're on line 3 and you're on Hello Health with surgical oncologist Russ Brown. Go right ahead.
Yes, thanks for taking my call. I apologize if this question's already been asked. I just came on to the show.
No problem.
My 18-year-old daughter had a pre-melanoma taken out of the back of her leg. How often should she be seen by a dermatologist and why?
So it depends. She needs to be seen at least a couple times a year. Probably early on after her dermatologist diagnosis, early melanoma, she probably saw her every 3 or 4 months, or at least scheduled a visit every 3 or 4 months. But she's probably going to be good friends with a dermatologist the rest of her life. There's not a hard number of months that we know. You can probably tell that this is just something, these are rough recommendations, but she needs to have a good dermatologist and a way, to access them if she has something new develop, and they're going to be looking at her closely.
Okay, so twice a year she should go in, whether or not she even sees a mold changing on her body?
I would recommend that, yes.
Okay, great. Thank you.
Better to be safe, right?
Yeah.
All right. And thank you so much for your call. We appreciate it. 504-866-3200 is our number. Line 1 is next. Patty calling us from Metairie. Patty, you're on with our doctor and our guest tonight. Go right ahead.
Hi, thank you so much. You had mentioned during the program about a targeted therapy for skin cancer. Can you expand on that a little bit, please?
Yeah, there's some drugs that target mutations that some melanomas have. So there's mutations in a gene or an enzyme called BRAF, B-R-A-F, and some melanomas have a mutation in that, and there have been developments where we can block that mutation and cause melanoma to regress or not metastasize, go to other places. That's a whole class of drugs. There's a few other classes, but that's one example.
Thank you very much for your call. And do you see this? How soon do you see this coming? Is it already out there and available?
Oh, those are available drugs for more advanced melanomas, for not for early melanomas that have been found on the skin and taken care of, but for melanomas that may have spread to a lymph node, spread to other parts of the body.
Okay, very good. 504, we have a couple of minutes left. 504-866-3200. We do have room for your calls and questions tonight. Line 2, Bill calling us from Harahan. Bill, thank you for your patience. You're next with Dr. Russ Brown.
I was just wondering what my chances are with melanoma. I have inherited psoriasis from my dad's side of the family, and have been taking UVB light treatment in the past. Do I have a good chance of developing melanoma?
So that's a good question. UVB treatment in itself would increase your risk of getting melanoma over someone who had not had UVB treatment. Psoriasis as a skin condition itself, I don't know that the psoriasis in itself is a risk for developing melanoma, but UVB treatment, which is commonly used for psoriasis and can help with some people, does put you at risk for melanoma. You're probably lucky in the sense that you're already seeing a dermatologist. They know that, and they will keep track of things for you.
Okay, thank you.
Bill, thank you so much. I appreciate it. So I know a couple of people who are dealing with skin cancer, and they come in on a regular basis, and they've got a Band-Aid here, and a Band-Aid here, and a Band-Aid here. Is it the kind of thing that's just kind of waiting to start? So it's all there, but it just starts, and then the minute it starts, like you said, to a woman who called, your daughter's going to get to know her dermatologist really well. Mm-hmm. It's once the ball rolling, the ball is rolling, the body just the cancer gets triggered.
Most of your friends who have Band-Aids everywhere are going to the dermatologist, and they're shaving things off or biopsying things that they're worried about. So someone who has a previous history of melanoma, well, that kind of gets our antenna up, and you'll find that the dermatologists are more apt to biopsy something in that person than they maybe wouldn't in someone who'd never had a history of melanoma. So it's not that every Band-Aid is a new cancer. It's just that sometimes that's what it takes to check and to be sure.
All right. Another email question, Doctor. Is melanoma always caused by sun damages, or is there other causes?
No, there's lots of causes. This is really a multifactorial thing. Rarely we will see children that have melanomas that are genetic problems. We can see people that have, we talked about this a little bit, but there's people that have terrible sun exposure that have no melanomas at all. They may have a squamous cell or something like that, and we see people that are that will never have a sunburn. Maybe they're dark-skinned and will not have that problem, and they're still at risk for getting a melanoma too. So it's, the take-home message is if there's a skin lesion that's growing, changing, that bothers your wife or your husband, go see your doctor and have it checked out.
All right. The other things we wanted to review in our summary is melanoma is on the rise, at least reported cases, right, of melanoma.
That's correct.
And you said either teetering on or looked at as an epidemic?
It's looked at as an epidemic because it affects the whole population, and it is on the rise. It can be prevented. Other take-home messages are that it can be cured, often with something as easy as a small office surgery. Sometimes we have to use many of the other tools we have to treat and cure melanoma.
All right. I want to thank Dr. Russ Brown for his work in the Oxnard Health System and for his the education and information he has provided tonight. Thank you so much, Doctor.
Thanks, Tom.
Okay, good to have you. Good words of warning tonight. Well, to make an appointment with any Oxnard physician, including tonight's guest, or to register for any of Oxnard's Hello Health seminars, you know they take place almost every week across the greater New Orleans area. You can all call Oxnard at this number, 504-842-5669. That's 842-5669, and it's a number set up just for viewers of this program. As a reminder, you can rewatch tonight's presentation or most of our Hello Health programs on our website at WLAE.com or on Oxnard's website. Lots of them there too at oxnard.org. Our thanks again to tonight's guest. Thanks to Humana and Oxnard for making our program possible. And our final thanks, as always, is to you for your support of this program, Hello Health, and our station, WLAE. Good evening.
Hello Health on LAE is presented by the Oxnard Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Oxnard Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Oxnard, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
No, we're just ready whenever you are. Trying to get the doctor on the way. Okay, thank you. Saints fan, huh?
Yeah, I grew up a Saints fan.
Yeah, good. Yeah. Here we go. Hi, I'm Tom Bagwell, inviting you to join us on Monday, June 26th for our next appointment with Hello Health. We'll be talking with surgical oncologist Russell Brown about melanoma and the surgical options for removing and treating it. It's all coming up on our next Hello Health. Oh, that didn't look right. Hi, I'm Tom Bagwell, inviting you to join us on Monday, June 26th for our next appointment with Hello Health. We'll be talking with surgical oncologist Russell Brown about melanoma and the surgical options for removing and treating it. Melanoma on our next Hello Health. It's all presented by Ochsner and Humana, and it's Monday night, June 26th at 7 o'clock, only here on WLAE. Hi, I'm Tom Bagwell, inviting you to join us on Monday, July 17th. It's your next appointment.